Hello, everyone. Welcome tonight. Thank you for attending our webinar tonight. We're very excited about our guests that are going to be speaking tonight. And I wanted to give you a little bit of an introduction. Unfortunately, as it would be, we have a few technical issues, so you're not actually going to be able to see, first of all, Dr. McCormick. And he is an associated professor of pediatrics at UPMC Children's Hospital of Pittsburgh. And he serves as the Healthy Transitions Program Director at the Down Syndrome Center of Western PA. He is a primary investigator of a national transition survey through the NIS and DS Connect, and speaks nationally about the importance of a longitudinal and holistic transition process. So we're very excited to have Dr. McCormick joining us tonight. And then next we have our very own Alexa Seybold. She is an occupational therapist with Positive Steps Therapy, and she works at our facility we call it the POI in Wexford, and it allows her the opportunity to treat both developmental conditions and orthopedic conditions. What Alexa loves the most about working in pediatrics is the flexibility and creativity it allows her to express as a therapist and the relationship she can build with families. Alexa was taught how to think outside of the box during her schooling, and it really pays off when working with kids throughout the lifespan. And then last but not least, we have Tomar Pearson-Brown. She's a clinical associate professor of law and director of the Health Law Clinic. Under her leadership, the Health Law Clinic has operated as a medical legal partnership with UPMC's Children's Hospital of Pittsburgh since 2015. She previously served as a clinical instructor and supervising attorney in the Juvenile and Special Education Law Clinic at the University of the District of Columbia. Prior to academia, she was an attorney with the Children's Law Center in Washington, D.C., and an Equal Justice Works Fellow with the Legal Aid Society of Cleveland. She received a JD from Case Western Reserve University School of Law and an LLM in Clinical Legal Education and Systems Change from the University of the District of Columbia, David A. Clark School of Law. So we are very excited to have all three of these experts here tonight to talk to you about transitioning for your children, adolescents, and teens. So with that, I'm going to actually turn it over to Dr. McCormick.
Well, good evening, everybody. I'm so glad that you could join us. And, you know, it's always a pleasure to be working with Tomar, because we've had a lot of opportunities to work together over the last couple of years at Children's thinking about transition. And I think it's really important that we start with that concept of collaboration. You know, I'm a physician and Tomar is a lawyer, but transition is such a holistic process that it's key that we work together. And really, I think about this concept of building a bridge, meaning that transition isn't something that happens in a moment, but it's a purposeful and planned process of how we help our young people move into adulthood. And that's really what we're going to be focusing on today. So we can go to the next slide.
I'm sorry, we seem to be having some sort of technical difficulty. It's taking me to a link. There we go.
And whenever I start talking about transition, I always want to ask kind of the background question of what is the purpose of transition? And I really think it comes from this concept of a model of value. I'll speak from the healthcare system. I think for too long, we have looked at disability as equivalent to disease, meaning that there's something wrong with an individual who has a disability. I work within the Down syndrome community, and so we think about the health problems that are associated with Down syndrome, and we think of those as diseases that we have to correct and change. But I think we really need a frame shift. So if we can go to the next slide. And really think of disability as more equal to diversity. And what I mean by that is, instead of viewing people from the things that we think need to change, we need to say, what are the things that are valuable about each of us as individuals? And what can we do that brings value to us as a society? Next slide. And so we really need a shift from disability to differently abled, because this concept really gets this idea that we learn from each other, and through this differently abled approach, we can actually add value to a society together. Next slide. So you can see this picture of someone who's text messaging, and this is just a great concept that kind of just solidifies this idea to me. You know, text messaging. We all do it every day. In fact, as we're talking, probably some people are going to be text messaging loved ones, saying what they're going to be doing later. But the reality is, right, where did text messaging come from? You know, cellular communication was this idea that we could talk on a phone anywhere in the world. But text messaging was actually born out of the deaf community. So we can see that people who are differently abled, who are hearing impaired, actually have added something to all of us, because it allowed those individuals to use cellular communication. And in fact, it's so important and so strong that it's almost become more ubiquitous than kind of verbal communication on cell phones. So we can see that text messaging, this idea of being differently abled, how it gives back to us as a culture. Next slide. And so we really need to start with this model of value related to transition, that when we think about people who are differently abled, that there is diversity, something that they bring to the table to us as a society that is so valuable. Next slide. And you may agree with me, but you may say, well, what does this have to do with transition? And see, transition is really connected to this idea of inclusion, meaning that if we really think that everybody has things that are valuable, that there's human dignity, that everyone who is part of our society has something to give back and is of value, then we have to realize that we don't want people only to be included, meaning that we know that our young adults are going to get older, that our young adults are going to move into the adult world, so they're going to be included, but we also want them to be valued. And transition is a way in which we make sure that they get to adulthood in a way in which who they are is intact. And so we can go to the next slide. And so I really want to talk about two problems related to transition that kind of lead to people not getting to adulthood in a valued way. And then we're going to talk about what is the concept of how we overcome these boundaries. And the first is the transfer leap. If I said that transition is this purposeful and planned process to getting to adulthood, transfer is really the mere physical change in location, moving from a child-based care to an adult-based care, moving from Children's Hospital to Montefiore Hospital. And it's this concept of just physical movement. And often what we hear is this idea of a transfer leap, that there's no preparation for our young adults. They get up to that age point where they age out of the kids system, and they now have to automatically get to the adult system, and they feel like they're crossing a chasm, that they're leaping, and that there's no support structure. And it's bound for them to have struggles and even fall through the cracks. Next slide. And even if there isn't a problem of a transfer leap, often our transition is done too late and incomplete. So it's like this rope bridge. So they're trying to cross this chasm, but the problem is they're about to fall through the cracks and fall into the river at any time. Next slide. So what we really need to do is build a transition bridge. It's purposeful and planned, meaning that it doesn't start when you're walking across that steel of the bridge, because a bridge has an on-ramp. There's a preparation phase. There's a way to build up to that bridge, that we make sure that our young adults are developmentally ready and that they have done all the appropriate things to make transition occur appropriately. They cross that bridge, but then there's also this off-ramp. There's this, as they move into the adult world, making sure that there's guardrails, that they have gotten to the adult world in a safe way, a check back. And so this idea is that it's not a moment in time, but it's this longitudinal approach to transition. Next slide. And what we're going to be talking about is these 6 core steps related to transition. And these are the 6 core steps as outlined by the Got Transitions website, which is a great resource. And we're going to kind of create a toolkit around these that say, how do we build medical transition based on these concepts? Next slide. But the problem is, it is not only that transition is done incompletely or too late, it also is done in silos. And what I mean is that often the school is worrying about employment transition. Physicians are worrying about healthcare transition. Maybe there's lawyers who are part of us, who are working with us, who are worried about legal transition or financial transition. And no one's thinking about, what about this community transition? And all of these are done in silos, and some are done well and some are done incompletely. And that's a problem. Next slide. Because really transition is more like a puzzle. Each of these pieces touch each other, so they interact with each other. And I know during COVID, we've all been doing large puzzles, and the worst thing in the world is when you have one single piece missing because that puzzle's incomplete. And that's the same with transition, because let me give you a great example. Let's say that a young adult has a great employment transition. The school's done a great job. They've gotten to college. They're on the road to employment. But we as physicians have done a poor job. And so this young adult who, let's say they have diabetes, has not had a good transition. And so when they move to the adult world, when they move to college, they don't understand how to manage their insulin correctly. They struggle. They have uncontrolled diabetes. They get hospitalized. They're now pulled out of school. And so we can see how each of these actually interact with each other. And if you don't do them in some way in concert, that's where you have problems. And that's why it's so important that myself and Tomar work together, because we're a team. We're thinking about, how do we help these young adults? Because they have holistic lives. We have to have a holistic approach to transition. Next slide. And before I jump into my toolkit related to healthcare transition, I want to leave you with this last more philosophical slide. See, this slide really looks at a graph, at a table that looks at as a child ages from early, middle, late into adulthood. And if you see, the concept is that the young adult initially, when they're in early childhood, are the receivers of care, and the parents are the caretakers. But as they age, we can see as they go down, eventually that young adult needs to be the supervisor and CEO, and really the parent needs to move into the consultant role. And what this means is that as parents, we need to pause and think about how we let go. How do we let our young adults become more independent? How do we give them responsibility? And how do we let them make mistakes? And for our young adults, this is the time to really push for independence in a way that you can build those skills, because it is so key. Next slide. So we're really going to talk about building this bridge. Next slide. And we're going to be talking about the key steps of discovery, tracking, preparing, planning, transferring, and completing. Next slide. And we're going to be doing this through this concept of a toolkit. And we're going to talk about a toolkit of an educational foundation, developing a transition, your transition visit, checklist, readiness assessment, transfer gear, and our graduation packet. Next slide. The first thing we're going to talk about is our educational foundation. Next slide. And this is really talking about the discovery phase. The discovery phase is saying that we have to have the end in mind before we start the journey. Meaning we need to dream. We all know that when we held our child for the first time in our arms and we're holding them, we're looking at them, we're dreaming about what their future will be. They'll have healthy relationships. They'll have employment where they make differences in the world. They'll have strong communities. That's what we want. But that doesn't stop there. As they age, we have to think about the end point of what we want their life to look like. And the way we do that is having a firm foundation of what understanding about the transition process is about. Next slide. And so this is about education. There's the old adage, if you build your foundation on sand, it will crumble, but if it's on a rock, that it will stand. And this idea is that we have to have a holistic understanding of what transition is built about. And so we have to think about healthcare transition, future planning, employment, legal. And what I'm saying is part of that journey is today, as you guys are here and participating in this webinar, but it also talks about going to conferences. Can you click for the next? And looking at other resources, online resources. I've been saying Got Transition is a great resource that you can kind of click through and look at these different aspects of transition and how they're built. Click again. There's also, like I said, conferences. So every year, the Pennsylvania conference on transition occurs out at Penn State. It's a great 2-3 day conference where you can do talks specifically around these different areas. If you're thinking, I want to learn about future planning, what about SSI? What about trust accounts? What about ABLE accounts? You can go and listen to specific talks about that to develop your understanding and your foundation. Click one more time. And then there's also the Transition Planning and Service Complete Guide. This was a recent book that was put out that allows you to go and reference these different topics. The idea is that as young adults and as families, we need to kind of drill down and get a baseline understanding of each of these concepts. I'll also say that every year, Children's Hospital has a free conference that they allow families to attend where we talk through each of these concepts as well. And we're always willing to have you join us for that. In fact, this Saturday, we're having a virtual version of that. Next slide. But as we move down the toolkit, we move from the discovery phase into the transition visit. Can you click to the next slide? And this really is the meat of what we're talking about. It's the tracking, pairing, planning, and transferring phase. This is where we're physically building the bridge. Next slide. And what I want you to realize is the first thing you need to think about is building your team. Because when you think about a transition visit, you may not have a transition clinic that you can specifically work with. You may not have that team already around you, but the key is you can help your team build a transition group around you. Next slide. And how are we going to do this? The first thing you always want to do whenever you're working with who are your medical providers and you're saying we need to advocate for transition is ask them about their transition policy. Because the transition policy is the agreement you have with your team about how they're going to deal with transition. When we talk about to families, we say, hey, transition is a purposeful and planned process. We are going to be working with you starting at age 14 all the way up till 18 to 21 years of age. We'll be seeing you every single year. And what we're going to do is the hard work of assessing your developmental readiness for transition and making sure you're on target. And the idea that it's between 18 and 21 years of age is that transition is different for each of us. And so you need to talk specifically with your team about what's their policy. You want to make sure that you're discussing that they have all the things they need to do. We're going to talk about checklists and readiness assessments and portable medical summaries in the next couple slides. But you know what? As you understand these concepts, as you've built your foundation, you can bring that information to your provider. And one final thing I'll also plug in there is you always want your young adult to talk to their physician alone. They can only develop independence if we let them have it. So at 14 years of age, that's a 5-minute conversation. Often I'm talking to young adults about interest in sports and things that are interesting in their life. But by 18 years of age, I'm spending time talking about their health and helping them work through that health literacy component of being a patient within a practice. Next slide. So after we have our team, after we kind of have some people who are on our side working with us, we have to do our work. And that's what I call start building your binder. These are the physical things you're going to do during transition to make transition occur. Next slide. So first, we're going to talk about checklists. Next slide. Checklists are the tracking phase. See, when we talk about tracking, we have to think about it as an airplane pilot who's about to take off. When the airplane pilot takes off, he goes through a list of hundreds of things in the plane that have to be working correctly. And what he has to do is make sure they all work before we take off. Transition is the same way. We have to track that all the appropriate steps are occurring, because if we take off from transition and something is missing, our kids can fall through the cracks. Next slide. So that is part of developing your individualized transition plan. Next slide. And this is an example of our checklist. So I always make sure that our families know, and we track this, that have we discussed the transition policy statement? Have we done a readiness assessment? If we've done a readiness assessment, which is in a way of making sure that our young adults are developmentally ready for transition, have we created goals for them now to move forward in their development? Have we created a portable medical summary? Have we discussed when they will transition to adult care and who that physician will be? One of the number one things families complain about is that physicians on the pediatric side aren't collaborating with families to help find adult providers. We need to do that work. And also, we need to start discussing early decision-making support. A lot of our young adults may need some support when they move into adulthood. So we start discussing things like power of attorney or guardianship if that's needed. Next slide. So one of the things I said was we also need to think about developmental readiness for transition. That's part of the visit. Next slide. And this is about preparing and planning. Preparing is about making sure where they're at in the readiness, and planning is creating those goals around it. Next slide. So the assessment and progress, go to the next slide, that we use in our clinic is called the TRACS, the Transition Readiness Assessment Questionnaire. And what we do is we have our young adults fill out this questionnaire on different domains related to self-care and health. And we say, what are they able to do? And there's 5 categories. I can't do this, but I want to learn. I'm starting to learn. I'm doing this consistently. I'm doing this every time. And we have them complete this assessment. And then afterwards, next slide, we have them create goals. So a good example is, and related to medication management, often our young adults aren't taking their medications independently. So one of the goals we could say is, our goal is to learn to take these medications independently. So we do an assessment, then we create goals. Next slide. Next slide. But after we create our goals, we can't just stop there. Next slide. We then have to help operationalize what we mean. Because if I give a family a goal of, let's just take our medication independently, that won't help. We have to say, well, what are we doing right now? And maybe the young adult requires their family member to go to the medicine cabinet, take the pill out and hand it to them. And we have to move towards independence, but only in a stepwise fashion. So the first thing I'll often say is, why don't you buy a pill tray? And the goal will be, you buy a pill tray and mom and dad and the young adult start filling the pill tray together every Sunday. And then the young adult with observation takes the pills independently throughout the week, so that eventually we've created a system that young adult can start developing independence in medication management. We have to operationalize these goals. Next slide. Also, one great resource that I'll put out there, and I can send this to the organizers at the end, there was a transition guide to medical transition that Children's and CMU created together. This is a great workbook that allow our young adults to work through some of these goals. Next slide. And it hits key topics on many domains, but there's specifically a category about me and my health. Next slide. And it talks about important things like, how do I talk to my doctor? If this is a place in which a young adult is struggling and this is a goal we've created, then we can go through this workbook and work on these skills together, giving them ideas of what kind of questions they can ask. How do they develop those questions before they walk into the doctor's office? Next slide. But it can also talk about appointment preparedness. Next slide. And medication management. So these are all skills that we can use these tools to strengthen what we're doing. So besides just learning to take my medication through a pill tray, I can also start discussing, what does this have to do with my medication management, and work on some of these skills through this workbook. Next slide. So then after we've gone through this stage of discovery, tracking, preparing, planning, next slide, then and only then can we think about transferring the physical movement to the adult world. Next slide. And I really think of transfer gear as the key component behind this. And for you guys, you need to be advocating for your physicians to be creating portable medical summaries. These are single-page documents that summarize the care of a young adult. So instead of a ream of 100 pages of their medical history, their physicians need to create a summary of what are the main medical challenges they have. How are they currently being managed? What medications do they use? What technology do they have? And at the very bottom, we have a list of providers. Who are the physicians that are taking care of them on the adult world and in the pediatric world? This is a way of talking back. So when an adult provider sees your young adult for the first time, if there are gaps in care, they know who they can talk back to. Next slide. And this transfer gear isn't just around the portable medical summary of healthcare, but it's all the other aspects that are key documents that you need to talk about. I'm sure that Tomar is going to be talking about power of attorney or guardianship, but there's other important things like a resume. You need to be developing resumes at young ages to work towards employment. Your financial documents, your state ID, your social security card, your will, if you need that. Next slide. And only after we've done all these steps can we really think about our graduation packet. The graduation packet is the idea that when we move to the adult world, it should be something that is celebrated. Next slide. And that is the completing phase of transition. Because if you remember, Our bridge has an off-ramp. It needs to make sure that when we get to the other side, it's done safely. Next slide. And so our graduation packet is a way of saying we finished our binder. We do a final checklist to make sure everything's occurred. We have an updated portable medical summary. In our care, we offer adult guidelines to care of people with Down syndrome. And we have to make sure that there's a warm handoff, that our pediatric provider is touching base with our adult provider. Next slide. And so this is really the process, and we help our young adult develop independence. We let our parents learn how to let go, to let the young adult be ready. But it's also the way in which our two providers work into this system to make sure that it occurs in an effective way. Next slide. So let's start this journey. Transition is a purposeful and planned process, and it's a journey that we need to walk on together. And I always like to end by saying this quote by Fred Rogers: transitions are almost always signs of growth, but they can bring feelings of loss. To get somewhere new, we may have to leave somewhere else behind. And I think this is really important as parents, that we say that transition is a time that we let our young adults have independence. And it's going to be hard, they're going to make mistakes, but that's how they grow. So I encourage you guys, think about transition as a holistic and longitudinal approach, and be advocates. Ask your team to do the work that they need to. Thank you.
Thank you so much. Alexa is up next.
All right. Okay, so just as Dr. McCormick said, I'm really excited to be here to talk about how occupational therapy and therapy in general can help with that transition, especially as kids, start to take on more and more. And I really loved how he touched on collaboration, because that is the core of occupational therapy. We strive to collaborate with families, teachers, advocates, whoever is involved in that young adult's life to make any sort of transition as easy as possible. So I'm going to touch on a few strategies that we use to help with those transitions, and ways how we can develop and modify and adapt any way that we can based on the needs of the child. So occupational, when we think of occupation, we think of a job. And so what is the job for a young adult or a young kid? So we really have to get to know the family, and I think that's something that is really beneficial of what we do as therapists. We really develop a bond with the families and their caregivers. So an occupational therapist, we evaluate the patients and determine how sensory, executive functioning, and activities of daily living could impact their ability to successfully transition. So this definitely incorporates collaborating with families, teacher, and the community to assist and make that transition as smooth as possible. We create programs that address the physical, behavioral, and emotional challenges of that transition, and identify the goals in which the family and the child has in order to succeed in the classroom, at home, and in the community. So in order to succeed in all of those different areas, we really look at sensory integration, how that impacts both negatively and positively, and also executive functioning strategies as well. Again, are they utilizing all that they can in order to successfully transition, or are there some areas where they could use a little bit of help? Next slide. So some treatment strategies may include modifying the environment to ensure success. So this could be in the classroom or at home, and this is as complex as physically changing something in the way that they're sitting, or as small as making sure that the computer that they're using isn't too bright and distracting them. We also work on fine motor and visual motor activities, how that relates to self-dressing, meal preparation, handwriting, and then we also use sensory activities. So the ALERT program uses the analogy of a train and an engine in order to describe describe the child's arousal level. So for example, if you're in high gear, you would be stressed out or energetic or hyper. In low gear, you're feeling sick, tired, lethargic. But if you're just right, you're alert, you're attentive, and you're able to participate. And then we use that model as the child gets older. So then we move into zones of regulation, again, talking about how we're feeling, getting that child to be a little bit more introspective, to use strategies to be in that just right zone at all times, so that we don't get too energetic and then we lose focus. Or if we know that we need a little bit more of a pick-me-up, to pay attention. If we're running a little bit slow, other strategies to get to that just right alert and attentive level. And then we develop sensory diets, which are specific again to the child, and it could include heavy work, movement-based tasks, tactile activities, weighted pressure vests, auditory input, and we use a couple different assessments to determine where that child is in that sensory diet. So we give the caregiver or the teacher or the parent a sensory profile to fill out, and that gives us a better look at what that child needs in order to be in that just right zone. And then lastly, we look at executive functioning activities. So this could include checklists, picture schedules, special seating, weighted materials, visual enhancements, organizers, and memory activities. Again, we're trying to help the child be as independent as possible, so that transitions at an early age help also then to transition at a later stage as well, because we're developing those independent strategies to maintain independence. Then a couple more treatment strategies that cover the sensory side of things. So we can desensitize the child and the young adult to their environment. So we remove that flight or fight tendency. So if we know that they're bothered by a busy environment, or if they get distracted by a lot of visual input, we can kind of modify where they're sitting or what environment that they're in, so that they're not as distracted. So kind of being proactive. And then we also could provide sensory input for the kids who need a little bit more to get their engines going. So that allows the child to attend to the activity in the moment versus trying to get input any way that they can. And then again, going back to the sensory activities and ways for the child to start advocating for themselves and learning these strategies to utilize independently, we talk again about the alert program, zones of regulation, and then an ongoing sensory diet. Executive functioning treatment strategies can address the following challenges: alertness, selective attention, sustained attention, mental tracking, shifting, divided attention, and time management, all of which we all do on a daily basis and don't realize that we're doing it. So again, we use an assessment, it's called the brief, and it is a questionnaire that the caregiver, the teacher, the parent fills out, and it develops this profile of what the child is having difficulty doing. And then once we know what may be challenging for them, we help develop strategies to make those things easier. So we give them some strategies to help with that short-term memory or selective attention. We plan and organize their school items or schedules that they have at home, and just make it a little bit, we modify to make it a little bit more tolerable so that they become more independent. And then I work very closely with speech therapists as well. So I'll touch a little bit about how they also help with transition. So they evaluate each patient's individual speech and language ability. And then they focused on individual language goals, such as teaching better communication, specifically pragmatics of speech, study skills. So again, going with the planning, organizing, attention to detail, and then controlling that impulsivity and interrupting. So more of those social impacts. And, you know, when a child was with a group of peers or adults, how they're interacting amongst a group. So along with other team members, they work with the teacher to change that classroom environment as needed. So again, sitting the student maybe in front of the classroom, or having the student repeat directions before following them, using checklists, and then other visual organizers to help with planning and follow through. And then lastly, we work with physical therapists as well. They focus on deficits caused by balance and coordination, health and exercise. As we know, exercise is known to benefit children socially and with their behavior. So just getting more involved in getting the whole body moving. It also helps increase the effectiveness of medication, or may help those who have not responded to medication to kind of just organize their overall needs. And then they work in conjunction with us as OT for coping strategies, maybe when something is challenging, instead of just giving up, how we can work through that and better cope with challenging situations.
Thank you, Alexa. Now we're going to welcome Tomar.
Hi, good evening, everyone. Okay, so yeah, I guess we'll just jump right in. So why should we be planning for our transition to adult care, right? This is a question that's really been laid out nicely by the two preceding speakers. I really have two key goals of transition planning that I focus in on to sort of summarize everything that has gone before from Dr. McCormick and from Alexa. So if you would click. The two goals that I like to focus on are the emphasis on continuity of clinical care that Dr. McCormick pointed out, but also this idea that there's a need for continuity in social care, right? Recognizing that teens are whole people, and especially as an adolescent's independent identity is emerging, they're not going to really want to be defined by their medical need or by their condition or by a physical limitation, right? Teens want to explore their independence, right? They want to think about where they're going to live when they get older. What sort of work are they going to want to do? What is their life going to be like when they're done with school? So if you'll click, you'll see that my emphasis is on transition planning that includes the social determinants of health, right? The things that go into our holistic health need in addition to our acute care needs. So if you'll click, the social determinants are the things that people need to be healthy outside of direct medical care. We know from the research that continuity of education and income and housing stability, the attainment of all of these things is tied to good health. So while your child's medical team might be among the best in the country at making sure that your child's physical health needs are met, you might have challenges accessing the things that make up these social determinants of health. And if you do, I would offer, and if you'll click ahead, that legal care can be a really important way of securing access to these social determinants, these things that make up the big picture of health. And for that reason, legal planning is consistent with the goals of healthcare transition planning. As Dr. McCormick said, all too often these things happen in silos, but through medical legal partnerships like the arrangement that I have with Children's Hospital, we're able to help families experience some integration of these legal services into their transition planning by actually offering legal services at the point of care. If you'll click ahead, I just have a friendly reminder as the lawyer in the room that teens become an adult without regard to their ability or health status under Pennsylvania law when they turn 18, right? So if you'll click ahead, when we're thinking about providing legal care, there are three main areas that I want to focus on with all of you this evening. You know, making sure that there's stability around self-determination and medical decision-making, stability around income assistance through supplemental security income, and continuity and transition around any special education that your child might be receiving. So if you'll click ahead, I will jump right into transitions around medical decision-making. And legal care in the form of legal literacy is often needed to ensure that self-determination and continuity of care as a social determinant of health remain stable as youth transition into adulthood. So if you'll click ahead, we'll remember that for minors, parental consent is usually required. If you'll click, the minor's biological parent is going to be the presumptive decision maker with just a few exceptions. So you'll want to click the next arrow twice and you'll see a bulleted list of exceptions, right? So we know that there are some teens that have limited ability to make their own medical decisions. And if you'll click to the next slide, we can sort of reframe this as a separate cohort of teens who are able to consent independently of their parents. But if you'll click, when a young person turns 18, there's a presumption of medical decision-making capacity. You can click, decision-making capacity is a clinical assessment of a patient's ability to make their own healthcare decisions. And a person who lacks capacity cannot consent to the treatment or the withholding of treatment. So if you lack capacity, you're going to need a substitute decision maker. Now, any clinician providing patient care should be able to perform routine capacity assessments. And if the capacity assessment is made and the patient cannot make their own decision, then we need to employ a substitute decision maker. So real quick on the next slide, I just want to remind you of the components of an autonomous choice. It's got to be informed, right? It's got to be based on information that your adult child is able to receive independently. The choice must be voluntary. It can't be coerced. It has to come from the patient, him or herself. And it also needs to be based on reasoning. Now, this is a clinical standard, right? This is a decision that is made by physicians and not lawyers. So sometimes we might be asked to weigh in on the ethics of a particular decision, but this is a decision that's coming from the clinical care team, and you can click ahead. And I would go ahead and click one more time. There we go. Right? So then let's talk about these tools for substitute decision making. There are 4 tools that I want to touch briefly on this evening. The first tool, if you'll click, is just social supports, right? So we're talking about a lot of big transitions, and I know that this can be overwhelming for parents. And so the first thing that I like to remind everyone is that relying on the adult primary in your life, even when you yourself are an adult, is a completely legitimate way of assisted medical decision making. And it's the way that all of us, I would argue, make our decisions, right? Regardless of ability or disability, we all rely on our parents as long as we're blessed to have them in our lives, or other adults that we trust to help us make the big picture decisions. And so you can remind your 18, 19-year-old son or daughter that even though that they're an adult and they have this independent, it doesn't take away from your independence to continue to rely on trusted adults for making decisions. But if you'll click to the next option, we can acknowledge that there are times when our capacity might fluctuate, right? When we might need to actually identify a person to make decisions on our behalf. And so if your child has capacity, they might be able to make out a power of attorney once they turn 18. And that would be a specific document that identifies a parent or a trusted adult to make decisions in the event of capacity. If you'll click ahead, a companion option is something under Pennsylvania called a healthcare representative. Now, under Pennsylvania law, even if you don't have the forethought or the capacity to execute a power of attorney before you find yourself in a situation where you don't have capacity to make your own medical decision, under Pennsylvania law, they will recognize a next of kin as someone who can make decisions on your behalf. So for example, if I were to be in a motorcycle accident, I can't speak for myself. My spouse, by legal default, would be the person who could hold themselves out as my healthcare representative in the event that I did not make a power of attorney before that incident. So how this might relate to your household is if your son or daughter is 18, 19, 20, they're not married, they don't have children, under Pennsylvania law, you are going to be the default representative. You can assert that you are the healthcare representative and make decisions on behalf of your son or daughter. If you'll click to the last option of guardianship, this is the most restrictive option, right? This is total subversion of the child's ability to speak for him or herself by the parent, right? And so we want to make this distinction between the healthcare representative and the guardian by saying, look, the healthcare representative can make medical decisions, but if an adult child is experiencing total incapacity, that they're not able to make decisions for their independent living, in addition to their medical care decisions, they very well may need an adult guardian. And this is when you're going to want to have a lawyer counseling you about how do I petition my court for guardianship? What are the responsibilities associated with being a legal guardian? Because it's a total subversion of the independence or the autonomy of an adult person. It's something that should not be taken into lightly, and we have the opportunity to help counsel your family among this array of tools as to what's going to be the most appropriate balance between allowing your child to exercise their independence within their limits and having an option to support them when a decision might be beyond their capacity to independently assess. Next slide. So what are some things that you can do as you plan for transition? You can click ahead, right? And think about what is your child's capacity? Who do they trust if they have some capacity to make independent choices? And then if you'll click, I think just twice more, you'll see that we have an array of options available depending on the capacity level of your adult child. Next slide. I want to talk briefly about SSI changes when you transition from adult to child. If you'll click ahead, I want to talk just briefly to remind you of the three-step consideration for childhood SSI. And you can click through so that all three bullet points come up. It's a three-step consideration based on the income of the child's household, the duration of the child's impairment, and whether the child's impairment meets medically equals or functionally equals a condition that's listed in the Social Security Administration regulations. If you're able to satisfy all three steps, you're eligible for SSI, which is that supplemental security income. It's cash assistance. There's no restrictions on the spending other than that it must be for the benefit, the well-being, the upkeep of the child. So this is a really interesting transition point because some children might be ineligible before 18, but find that they're eligible when they're 18 because the household calculation might change if their living situation changes. If they go to some kind of independent living, all of a sudden they become their own household, they might be eligible. But for children who are eligible under the childhood rules, when they turn to adulthood, they might find that they are no longer eligible for SSI because the process now adds 2 new steps. So if you'll click twice, you'll see that step 4 is added. Does the person have the capacity to work? Becomes a consideration that was never asked of a child, right? We don't ask whether children can work in the general economy. Those are only questions for adulthood. And so depending on the child's special need, SSI might consider in their adulthood that they no longer have a disability, even though the condition hasn't changed, the diagnosis hasn't changed, they no longer have a disability because now what we're evaluating is work capacity based on the determinations, in contrast, excuse me, to the determination that was made for a child. So if you'll click ahead, there's a couple of points that you might want to consider as you're planning for transition. And if you'll click once again, yeah, so I want to hang out here for 1 second. Oh, if you could click back, yeah. So I just want to emphasize these points of actions that you can take as you plan for this transition, right? Document your child's limitations, especially around that age of 16, 17, 18. because SSI, the Social Security Administration, tends to start evaluating young people for that transition to adulthood around age 17, right? They want to make sure, is this person still going to be eligible or not? So you want to begin early to document that even though this person is now going to be assessed under the new standard, that they cannot do work, or if they can do work, what are some ways that you can make sure that that income still comes into the household if you're otherwise eligible. So to that end, I would encourage you to investigate the Social Security Administration's work incentives. I would encourage you to speak with your local Social Security office about what programs exist to support workforce development for persons with disabilities. But most importantly, please seek legal counsel to assist with your appeals. That denial notice that comes in the mail is not final by any means. There are oftentimes avenues for families to push back on a finding of denial of benefits, but it's really difficult to do that on your own. It really requires the support of legal counsel. Okay, we can click ahead. Lastly, I want to touch on special education. And I want to talk about transition planning around the IEP as well as the 504 plan. So if you click through, the Individuals with Disabilities Education Act applies to students with specific named disabilities, right? So you might be familiar with this list. If your child has any of these impairments, they probably receive an IEP while they're at school. Next slide. So when a child turns 14, the IDEA requires that transition planning become part of the IEP development process. And I just want to emphasize under number 2 that the transition services have to be specific. They have to assist the student with a disability in reaching named goals. And when Dr. McCormick was talking earlier this evening about that goal planning, about integrated team planning, I want to emphasize to you that the transition planning portion of your IEP meeting is a really underutilized opportunity for you as parents to bring people from the diverse sectors of your child's life together to make sure that the goals that are going into that IEP are specific, are measurable, and are reasonably calculated to help them achieve their post-secondary goals. Next slide. So it's important to remember that under the IDEA, the transition planning tends to transfer to the child at the age of majority, but under Pennsylvania law, the age of majority for education is 21. That means that as a parent, you are able to continue to be that ultimate IEP decision maker all the way until your child turns 20, and the IEP will go, their eligibility for special education services goes through the end of the school year in which they turn 21. You can click forward. So really the key thing in planning for transition with respect to the IEP is to ask, does the transition plan contain these appropriate, specific, measurable goals? And the best way to make sure that it does is to follow Dr. McCormick's advice and really pull in the perspective of everybody on that team so that you're going into that IEP meeting prepared with information about where your child is headed. I would also encourage you to contact local vocational programs, Bureau of Vocational Resources. Make sure that somebody from that agency is coming to the IEP meeting and talking about things that are available in your county. Everybody in different places in Pennsylvania has access to different resources, but having that person available and at the table at that meeting is crucial. I can't stress the importance of that enough. I would also encourage you to seek your educational advocates. Someone like myself, someone from the Peel Center is a really great resource to parents in Pennsylvania if the child is not making progress towards their transition goals or the goals are inappropriate. And by inappropriate, I mean substanceless, that they don't make sense for your child's particular needs. And you can click ahead. Oh yeah, that was a big one. You don't have to click back, but just teens should start participating in their IEP meetings. So often young people, especially when they're elementary school, it might be appropriate to not have them in their IEP meeting. Some, very young people don't know that they have an IEP, but when they turn 14 and into their teenage years, it's really important that students come to their IEP meeting so they know what the content, what the substance of their IEP is, and so that they can be a voice for planning. Really quickly, I want to touch on Section 504 of the Rehabilitation Act because not everyone has an IEP, but some families have 504 plans. So you can click once again just to get a little bit of information about what Section 504 requires. I always help parents distinguish between a 504 plan and an IEP by calling them to remember Stephen Hawking, who wrote A Brief History of Time, right? Stephen Hawking was the smartest guy in the room, of every room that he ever entered, most likely. He didn't need an IEP. He was able to access the curriculum, but he probably needed a Section 504 plan, right? To make sure that there was a ramp, make sure that there was assistive technology so that he could access the school building. So that's an easy way to make the distinction between an IEP and a 504 plan. IEP is about access to curriculum. Section 504 is about access to the school facilities. Next slide. So Section 504 doesn't require that eligible students receive transition services as defined in the IEDEA. However, 504 plans can be really important documents to assist in a student's transition to post-secondary education opportunities. You can go ahead and click. So while it's important to remember that schools aren't required to make adjustments or provide aids and services that fundamentally change an academic program or impose an undue burden, that accommodations do need to be made to the school environment. So while a IEP or a Section 504 plan won't follow a student to a college program or to a vocational program after they go through their K through 12 program, it can be really important in documenting that this young person succeeds in this environment when they have these accommodations, right? It shows how they can succeed in a workforce, how they can succeed in a higher education environment, and can be a really important basis for accommodations that organizations are going to be required to provide under other statutes in their pursuits, in their vocational pursuits or in their educational pursuits after high school. Next slide. So just again, to summarize, the real key question when you're planning for transition is what accommodations is my young person currently receiving that should be documented to make sure that as they transition into the workforce or into other educational opportunities, that they're still supported. So if you'll click again, there's a couple of actions you can take. Make sure that that 504 plan is being updated. Make sure that it's detailed. So often schools will say, oh, well, we do that. We don't need to write it down. And you want to sort of advocate for your child just a little bit and say, you know what, it's really important, not just for what happens in school, but for what happens after school, that we're really making sure that we're keeping a detailed account of every accommodation that's being provided. And again, please feel empowered to seek legal counsel or to seek a parent advocate if you're having a hard time getting a 504 plan at all or getting specific accommodations documented in the 504 plan. You can click ahead. That was my really quick summary of some legal perspectives to keep in mind while you're transition planning. And if we have time for questions through this webinar, I'm happy to hang out and receive any questions that you all might have. Thank you so much for your time and attention.
Wow, thank you, Tomar, Dr. McCormick, and Alexa. This was awesome. So we did leave a little bit of time for questions. So if anyone has questions, if you would like to enter them in, and then Lauren can review them with us, with our team of experts. We'll give it a couple seconds. Lauren, no questions coming in?
Nothing that's come in, but if people have questions afterwards, you can always reply to the reminder email you got about the webinar, and we're happy to direct you to the appropriate person to help you out.
Yeah, and also we'll be sending out a survey, so please let us know how we did, and also, as importantly, what we can do in the future. What topics are you looking for, so we can pull together wonderful resources like we did tonight to be able to help with any questions that you have on your journey with your child. So everyone have a great night, stay healthy, stay safe, and thank you so much. Thank you so much, Dr. McCormick, Alexa, and Tomar. We really appreciate your support tonight.
Yeah, thank you for having us.
Thank you for the opportunity.
Yes, thank you.
All right, thanks, guys. Take care.
Bye-bye.
Bye-bye.
Bye.